Nane. I am consultant physician in medicine department. Today we are going to discuss about the general sign and symptoms of respiratory disease and respiratory examination as well. So we will start with the objective of this session is to assess the thorax and the lung examination and respiratory sign and symptom. This is the most important topic which we are going to discuss today. And then for symptom, we will discuss each and every symptom in detail separately. And then we go for the examination of the respiratory system. And then I will guide you how to assess the sign of the respiratory diseases. And at the end, we will discuss the relevant examination of the respiratory system. So next, these uh, cross areas shows the main symptom for which the patient present to us. Number one is shortness of breath. In patient present with the difficulty in breathing and the patient उर्दू में कहेगा जी डॉक्टर साहब सांस नहीं आ रहा. And secondly, patient may have wheezing, कहेगा जी सांस के साथ सीटियाँ बज रही हैं. And third, patient have chest pain with breathing. And number four, patient have a sputum and may present with the hemoptysis, blood streak sputum. These are the symptoms which we discussed, the four main symptoms of the respiratory diseases. And then it is very important to assess on the basis of the history for respiratory infections, any history of respiratory infections, smoking history, and environmental exposure, and self-care behaviors. Next, the cough, most important symptom in the respiratory diseases which we are going to is cough. Cough by definition is sudden explosive action against an initially closed glottis. Cough is divided into two parts, acute cough and chronic cough. The acute cough, which lasts from less than 3 weeks, is most common in the acute viral upper respiratory tract infections, self-limiting, and it is really benign in condition. May have red flag symptoms such as hemoptysis associated with cough, and cough patient may have associated fever, chest pain, and weight loss. And chronic cough is which lasts more than 8 weeks. We classify as it's a chronic cough. Less than 3 weeks, acute cough, and more than 8 weeks, it is called chronic cough. So next, we will discuss about the each symptom and type of cough associated associated diseases with cough. Asthma, which have a prolonged wheezing coughing. पेशेंट कहेगा जी खांसी करते वक्त सीटियों की बहुत ज़्यादा अंदर से आवाज़ आती. Associated disease is asthma. And in cough with associated lung cancer is non-explosive bovine cough with hoarseness. Patient and in cough in laryngeal inflammation is a harsh barking cough. Patient have very painful harsh coughing is associated in disease is laryngeal inflammation. And third, in cough in moist cough, associated cough we associate with sputum is always and bronchial infections, and bronchiectasis. Persistent moist cough in smokers. Diagnosis is chronic bronchitis. But cough which is dry and centrally painful, non-productive, or maybe productive, and associated fever, so disease is pneumonia. Uh, Timing associated features of cough are nocturnal cough. Patient have जो कहेगा रात को कफ बहुत ज़्यादा होती है और लेट नाइट कफ है अर्ली मॉर्निंग कफ है always patient have a asthma bronchial asthma is your number one diagnosis. Daytime cough is usually due to occult gastroesophageal reflux disease and chronic sinus disease. Dry cough with medication. After medication is usually associated with EC inhibitor use and coughing during or after swallowing liquid is neuromuscular diseases of the oropharynx. Large purulent amount of sputum associated with cough, varying with postures, your diagnosis will be bronchiectasis. Sudden large amount of purulent sputum or a single effusion, rupture of a lung abscess or an empyema. Large volume of blood, watery sputum with a pink tinge in acutely breathless is pulmonary edema. So, uh, so far we cover the cough. And second symptom is which usually patient present is sputum, and on the examination of sputum you can diagnose the case roughly whether patient have a diseases of upper or lower respiratory tract infections, such as if a sputum is of clear watery, you can't, it's a serious sputum, and the causes of such type of sputum is acute pulmonary edema. Or patient may have a frothy pinkish sputum. It is always in acute pulmonary edema and alveolar cell cancer. Clear gray sputum is mucoid and it's always in smokers, COPD patients. White viscid sputum is in asthma, and purulent yellow sputum, which is always in pneumonia, acute bronchopulmonary infections. And third, purulent type of sputum is green color sputum, which is always in long-standing infections, pneumonia, bronchiectasis, and more importantly in cystic fibrosis and lung abscess is produce a greenish and purulent type of sputum. A rusty red sputum is always a pathognomic for pneumococcal pneumonia. No, if the sputum is associated with blood stain, you call is a hemoptysis. The most common causes of hemoptysis are pulmonary infection, carcinoma of lung, abnormality of heart or lung blood vessels, and pulmonary artery or vein abnormalities. And at the end is pulmonary embolism. After cough and sputum, third more symptom which patients usually present with you is shortness of breath, breathlessness. is defined as feeling of an uncomfortable need to breathe, is called breathlessness or shortness of breath. Later on, we will discuss about this MRC dyspnea scale in fourth year or final year. But at your stage, you have to remember the definition of breathlessness and the causes of shortness of breath. There are two major systems which produce shortness of breath: respiratory or and cardiovascular systems. Uh, Acute dyspnea associated in respiratory diseases is caused by asthma, COPD, acute exacerbation, pneumonia, pulmonary embolism, ARDS, viral pneumonias, such as like in we are facing a pandemic of coronavirus. Patients usually present with acute dyspnea, acute shortness of breath. And the causes of chronic dyspnea or shortness of breath is patient have a prolonged history of months to years. It's caused by COPD, chronic asthma, bronchial carcinoma, interstitial lung diseases, and chronic pulmonary embolism. A large amount of pleural effusion can produce a chronic dyspnea. Later on, we will discuss about cardiovascular diseases which causes shortness of breath. No, the third most symptom is cause of chest pain. Chest pain which increase on deep inspiration is always due to respiratory disease, and the chest pain which is not aggravated or relieved by breathing is maybe associated with cardiac diseases and musculoskeletal type of chest pain. No, here we will discuss only the causes of chest pain, pulmonary causes of chest pain. Number one is pulmonary infarction, pneumonia, pneumothorax, tuberculosis, malignancy, and pulmonary embolism. We cover all the symptoms which the patient present to you, and no way will go for the signs of respiratory system. For sign, you have to examine the chest and examine the patient thoroughly. And four basic part of examination of respiratory system is inspection, palpation, percussion, and auscultation. Always make an habit of have a general appearance or look for the patient. On looking of the patient, you can count the respiratory rate, which is normally is 14 to 20 cycles per minute, and if it's more than 20, is you can call it a tachypnea, and if less than 12, it is a bradypnea, which causes are we will discuss in later on with diseases. So on looking, you will count the respiratory rate, and secondly, you will see is the respiratory cycle is rhythmic, patient have a regular breathing or have a rapid or shallow breathing. Rapid and shallow breathing is caused by a metabolic diseases, metabolic acidosis, severe anxiety, exercise, or maybe in respiratory infections. So always make a habit of looking the face of the patient. This is a picture of a lady which have a obstructive airway disease, chronic obstructive airway disease, showing a prominent sternocleidomastoid muscles due to the increased effort put on during inspiration. She developed a hypertrophy of sternocleidomastoid muscles, trapezius muscles, and retraction of supraclavicular or infraclavicular foci, and substernal retractions. Subcostal retraction is can be seen in this patient. Next, look, watch, and then listen. Listen for stridor. Stridor is an audible harsh sound during inspiration. Is caused by an upper airway obstruction. Stridor is very harsh, loud sound. In contrast, a wheeze is less loud, whistling sound, and but it could be audible by both patients and for doctors. Wheezing is caused by partial airway obstruction from secretions, tissue inflammation, or foreign body. Like wheezing is a pathognomic for bronchial asthma and in viral pneumonias. Then, by looking the face of the patient, you can also see the color of the patient. Is the color of the patient is bluish? It's a cyanosis. The cyanosis is caused by hypoxia, and there are two type of cyanosis. One is central cyanosis, which is of the lips and the tongues. As in this picture, patient have blue discoloration of his tongue, lips, and this is usually caused by asthma, COPD, acute COPD, and pneumonias and pulmonary fibrosis. Other type is peripheral cyanosis. Peripheral cyanosis is seen over nail bed, toes, nose, tip of nose, and ear lobules. As in this picture, it shows the bluish discoloration of fingertips and nails. Next is you go for see the clubbing. Clubbing is curving and roundness of thickening of the fingernails. Okay? It is caused by respiratory diseases and as well as in cardiovascular diseases. Here we will discuss about respiratory causes of clubbing, which is number one is lung abscess, bronchiectasis, and empyema. And other is bronchogenic carcinoma, malignancy of lung. This is a picture of normal finger which have a nail to finger angle is less than 160, but in club finger have a angle is more than 180. There are four grade of clubbing which we will teach you in clinical classes in the when you come in the wards. Here, just remember the causes of clubbing, grade, and how you will assess the clubbing. Then, so we are here in only so far on inspection of the patient. And inspection of the neck, you can find the sign of the respiratory diseases. His patient have a contraction of sternocleidomastoid, accessory patient have accessory muscle using accessory muscle of the respiration, and tracheal tug, tracheal midline deviation in pneumothorax, pleural effusion, and atelectasis. From neck, go to see the shape of the chest. There are few types of chest shape: a pigeon chest, and causes are rickets and congenital causes. And number two is pectus excavatum, funnel shaped chest, as shown in this picture. This is caused by rickets, congenital heart diseases, congenital rib musculoskeletal diseases. And this is a barrel shaped chest. Barrel shaped chest is seen in the patient of COPD, where the interior posterior diameter of chest is more than the lateral diameter of the chest. Then we will see the movement of chest. Either the patient have chest movement is equal, bilaterally or symmetrical, or have asymmetry. Causes of unilateral lagging due to unilateral decreased chest movement is due to pneumonia, consolidation, pleural effusion, and pneumothorax, pulmonary fibrosis, and collapse. Then we will go to the second step of the examination, which is palpation. So, palpation is started from the trachea, from the position of the trachea. Normally, trachea is lying in the centrally and slightly shifted toward the right side. Displacement of the trachea is caused by uh, toward the side of lesions. If the trachea is toward the right side, then patient have a right lung fibrosis or collapse. But if the patient have trachea may be away from the side of the lesion, such as trachea is pushed to the opposite side, as in if the patient have a fluid in thorax, such as pleural effusion, air, pneumothorax blood, or lung mass. Pain and tenderness over the chest is usually due to pleuritis and refractures and costochondritis. Then we will go for how to assess the anterior chest by placing your hand at costal margin with marking skin fold, making making skin fold, asking to inhale and exhale, and looking for symmetry of the separation of thumb as shown in the this picture. And from posterior side, same procedure is done. You place your hand and thumb is medially and ask the patient to take a deep breath. You will see the movement of your thumb. If it's normal and equally both sides, it's okay now. And then we will, by palpation, you have a tactile fremitus. Tactile fremitus is speech created vibrations. When one palpates the chest wall, these vibrations can be felt and are termed tactile fremitus. Ask the patient to say 99, 99, and you will place your hand like this way. You can assess a vibrating sound in both sides of the chest. This is called tactile fremitus. Tactile fremitus, these are the areas which shown where to assess, and this is the causes of increase or decrease tactile fremitus. Condition which increases the tactile fremitus is consolidation in pneumonia, atelectasis, and lung mass. And the condition which decrease the tactile fremitus is pleural effusion, either a flute, air, pneumothorax, or thick chest, it's like obesity and thick chest wall. Thick. Third step of is percussion. So we will cover inspection, palpation, and now the percussion. By tapping on the chest wall and determining the nature of the underlying structure is air filled, fluid filled, or solid. To identify level of the diaphragmatic dullness and to assess the diaphragmatic excoriation, Percussion is very important in such a ways. This is a picture of a patient, then how to percuss the chest wall. And hyperextended, the middle finger of your left hand is placed. Percuss hyperextended finger distal interphalangeal joint on the surface to the percuss void surface. This is the procedure of percussing which will demonstrate when you will come in wards of the medicine. No, remember these three type of percussions: stony dull percussion, which is due to pleural effusion or lung mass. Relevant dullness is due to pneumonia, collapse, or fibrosis. And number three is hyperresonance. Either percussion note is stony dull, as in pneumonia, as in pleural effusion and lung mass. Impaired dullness or relative dullness is seen in pneumonia, collapse, and fibrosis, and then is a hyperresonance, which is seen as if the air in the thorax, pneumothorax, or emphysema. These are same uh, table which we will discuss previously. And fourth step is auscultation. So auscultate the chest with a stethoscope. Normal air is good air entry bilaterally, and if you find an abnormality, it could be a unilateral decreased air entry, which is seen in a pleural effusion, lung collapse, pneumonia, pneumothorax, and foreign body or mass in the airways. Bilateral decrease air entry is auscultated when patient have emphysema, thick chest wall. There are the four types of normal breath sound seen: tracheal breath sound, bronchial breath sound, bronchiovesicular, and vesicular. These are the where in trachea the inspiration and expiration is equal in time. In bronchial breath, decrease time for inspiration but increase for expiration. This is called bronchial. Other two type we will discuss in later on. So normal breathing is vesicular breath sound, and if they are soft, low pitch type of breathing, but the bronchial breath is always pathological and is usually seen in the patient of pneumonia consolidation. Any others added sound which would be auscultated are crackles, wheezing, rhonchi, and pleural. Crackles are sorry. Crackles are short, discontinuous, non-musical sound heard mostly during inspiration. There are two type of crackles. Either patient have a coarse crackles which are seen in the pneumonia, bronchiectasis, and pulmonary cavity. Fine crepitations, always remember in the patient have when the alveoli is fluid fill, seen in pulmonary edema or congestive heart failure. Wheeze. Wheeze is a musical high-pitched sound heard mostly during expiration, and is produced when the air passes through narrowed bronchi. A musical whistling sound is produced. And this wheeze is, as I discussed previously, is most commonly seen in bronchospasm of asthma. Rhonchi. Rhonchi is our lower pitch, more louder sound than wheezing. They are believed to be more common with transient mucus plug and poor movement of the airway secretions. Stridor is very harsh, loud sound and is seen in partial or complete obstruction of larynx or trachea. So we will cover so far inspection, palpation, percussion, and auscultation. Hopefully, you can now see and pick the sign of respiratory diseases. At the end, we will discuss about the baseline tests which are necessary to investigations which are necessary to confirm your diagnosis of any pulmonary disease. Pulmonary function test is important to uh, differentiate between obstructive lung disease and restrictive lung disease. Pulmonary function test is important. Other are ABGs, pulse oximetry, sputum culture, and sputum microscopies, and then are imaging studies, which is very important in early and gold standards for the diseases of respiration is chest X-ray followed by a CT scan of our chest. Other are MRI, fluoroscopic studies, pulmonary angiography, and if you are suspecting a lung mass or cancer, go for biopsy. And then other are endoscopic procedures like bronchoscopy, thoracoscopy, and thoracocentesis. This is a X-ray of standard chest X-ray of PA view of a patient showing bilaterally lung fields, and in the center there is a white shadow is heart. Air in the lungs are seen up in black. This is another picture where this is our trachea, and in lower part and the right side there is a liver, and on the left side this is a stomach, and this is the heart. In the right border of the heart is made by usually right main stem of bronchus, pulmonary arteries, and right atrium. The left part of the heart is seen in aortic arch, pulmonary artery, and left ventricular. And this is a diagnostic gold standard test of diseases of pulmonary in pulmonary diseases, and we will discuss in later on with every disease when you will learn the each and every disease in detail. Initially, here I am showing you a gold standard test for pulmonary embolism. It is D dimer is gold standard, and in cystic fibrosis caused by leading to emphysema, alpha 1 antitrypsin deficiency test is gold standard for, and lung cancer tumor marker, pneumonias we will go for chest x-ray, CT scan, sputum cultures, and in TB infection tuberculin skin test and interferon gamma test is gold standard. And other diseases such as sarcoidosis, AC, angiotensin converting enzyme levels. In asthma, you have to skin allergen test, and the eosinophilias, which we will discuss in later on with the detail. No, thank you very much. Of if you have any question, type type it on the chat box. I am here, and we will discuss it. Sarcoidosis, you want from sarcoidosis is a granulomatous disease which is a multi-organ disease, and you see the granulomas of sarcoidosis, which is a non-causative granulomas seen in the lungs, heart, eye, skin, and which we will discuss in the later on in detail when we learn about all the diseases individually. And ACE, angiotensin converting enzyme, is a lab investigation for sarcoidosis, and biopsy, which shows non-caseating granuloma, is a confirmatory and test for sarcoidosis. Any other question, please? No, exercise asthma is not always a normal condition. Exercise asthma is exercise induced asthma is a um, risk factor. Exercise, occupations, exposure to environmental factors, and exposure in workplace, they are all the risk factor for asthma, and it is not always normal in asthma. I think you are missing a question. Actually, your question is not right. Patient is short of breath in during exercise. This is not an asthma. If you want to ask this, shortness of breath is a normal in exercise, but it is not an asthma. Asthma is a tetrad of four symptoms and sign, which is shortness of breath, chest tightness, wheezing, and coughing. If a patient with have a so asthma by definition, asthma, if your symptom of asthma is precipitated by an exercise and four symptoms come, which is coughing, chest tightness, wheezing, and chest tightness, wheeze, and cough. These all symptoms come with exercise. It is called a exercise asthma, and it's not a normal. In stress-induced shortness of breath. Yeah, you have a very basic question. Stress is a factor which can cause shortness of breath, but when a patient with present with the shortness of breath in emergency, always first think about respiratory diseases, then cardiovascular disease, and at the end you will see it's just a stress or anxiety which can cause a shortness of a breath. But initially, two basic or causes of shortness of breath are respiratory disease or cardiovascular disease. Any other question, please? So I think you have learned a lot of our thing about the respiration. You have no more questions. Okay then. Thank you. If you have no question, let me. I will ask you a questions. I am typing. So tell me about the causes of decreased vocal fremitus. Anyone? Anyone? Causes of decreased vocal fremitus in the right side of chest. No? So I think it's a difficult for you guys. Uh, okay, tell me the causes of hemoptysis. Dr. Manur Salim, Dr. Uswa, asthma, COPD. Okay. Now, what are the causes of hemoptysis? COPD can't cause hemoptysis. Yes, pulmonary edema. Patient have a hemoptysis in pulmonary edema. Okay, trauma. But tell me the basic such hemoptysis. Number one, when the patient present with the hemoptysis, think about any malignant disorder like malignancy of lung or pneumonias. Okay, and now tell me the causes of stridor. No, causes of stridor. Causes of stridors. Yes, Maham, you are right. Blockage of upper respiratory tree, not a lower. Lower respiratory produce wheezing sound or ronchi, but upper respiratory tract blockage produce a stridor. Okay, well, Manoj, th- thank you, well done. Okay, uh, let me ask something more about this. Hmm. Okay. What are the causes of chest pain? Okay. Cardiovascular, angina. Tell me about the respiratory causes of chest pain. Well done, Uswa. Asthma and chest pain or due to a respiratory cause is always increased with deep breathing. In contrast to a chest pain caused by a cardiovascular disease, which is not related to our breathing pattern. No, no collapsed lung can causes pulmonary edema. Chest pain. Okay, लेकिन tell me common causes first. Uh, okay, fine. Pulmonary embolism. If patient have a chest pain which increase with breathing, number one differential in comes to your mind is pneumonia, and number two pneumothorax, and number three, okay, trauma. Okay, fine, fine, excellent. I hope you will rheumatoid arthritis. I ask you about rheumatoid arthritis can cause costochondritis, but I specifically ask you about respiratory causes of the chest pain. Okay, fine. So far, you guys perform well. Any other question? Emphysema. Explain, Manur. Explain what you want to ask about emphysema. Emphysema is obstructive airway disease which causes chest tightness, but it not typically present with a chest pain. Yes, gastroesophageal reflux issues can cause central chest pain. Corona corona symptom is not typical for tetrad of the coronavirus infection is chest pain is not included in that. In coronavirus infection, patient have a upper airway infection sign like sore throat, sneezing, flu-like symptoms, and later on patient sudden present with shortness of breath instead of patient have a chest pain. Shortness of breath, cough with sputum. Okay, thank you very much, students. Okay. If you are still have a queries, I am typing my email address. You can ask me on my email address.